Good evening, everybody. At the outset, I would like to thank the organizing committee of the 19th Annual Women's Cancer Initiative Conference of Tata Memorial Hospital. The task which is given to me, the Asian Perspectives of Breast Cancer, I'm supposed to speak on BCS versus MRI, the reality. If you see the timelines of breast cancer surgery, it took almost 100 years to reach from mastectomy, the era of Halsted mastectomy, to breast conservation therapy. It took almost 70 to 80 years. So despite level 1 evidence which is available, we are still grappling with low rates of breast conservation surgeries in low and middle income countries. So if you see the timelines, now we are in the current era of de-escalation, treatment optimization, sentinel lymph node biopsies, oncoplasties, and risk-reducing surgeries. What are the factors that have contributed for change in surgical approach? The better understanding of the tumor biology, awareness, screening, downstaging, advances in imaging, advances in systemic therapy, radiation therapy, high-quality clinical trials. Last but not the least, the surgical leadership, introspection, and willing to change. Breast cancer is a great success story and a role model in the field of oncology. It laid foundations for clinical trials, multimodality management, organ conservation and de-escalation, cross-collaboration with other surgical specialties like plastic surgery, and it also laid foundations for a holistic patient-centric treatment approach. Most scientifically studied and validated therapeutic intervention in the field of breast surgery is breast conservation therapy. The study started in 1960s. Then we have a lot of retrospective studies, landmark randomized controlled trials. Now we have data available with 20-year follow-up for breast conservation therapy. Now we are in the era of expanding indications for breast conservation therapy, especially the big game changers of neoadjuvant chemotherapy for LOBCs and oncoplasty for patients with adverse tumor breast ratios. So these are a few examples where we are pushing the boundaries as far as BCS is concerned. The eternal question, the survival impact of BCS versus mastectomy. Now we have started seeing it is now, we are not looking at equivalence of survival. We have now big studies coming, the Danish study, the Swedish study showing superior survival for patients undergoing breast conservation therapy. This is the Danish study, and this is the recent publications in JAMA surgery from Swedish National 6-year follow-up, 48,000 women data, which has shown a survival benefit for patients undergoing breast conservation therapy. So despite availability of strong level 1 evidence, we still see a very low BCS rates in low and middle income countries because of multiple factors, including surgeon-related factors, resource-related factors, and patient-related factors. Let's have a look at the global mastectomy rates. This was little old data which I could gather at the time. It ranges between 30 to 60%, the mastectomy rates in Europe and North America. We don't have a large national level figures for Africa and Asia. At that time, it used to range between 80 to 90% mastectomy rates at a national level. So this was one of the studies published, a multi-center study from India in Nature, where they have shown out of a cohort of 3,400 patients, the breast conservation rate was 21% in India. So the current study, which was initiated for this conference, the Asian Perspectives, I would like to congratulate Dr. Neeta Nair and all the participating centers. A total of 7 centers have participated in the study. 3 centers from North India, 2 from West, 1 from East, and 1 from South India. 5 centers provided data for 2 years, that is 2018 and 19, and 1 center and 2 centers provided data for 2 years. A total of 7,674 patients surgical data was analyzed for evaluating BCS rates among Indian patients. So this is the glimpse of data which was contributed by individual centers here. The first 5 centers contributed 2-year data, and the last 2 centers contributed data of only 1 year. So in total, we had almost 7,000 odd patients for this study. So let us look at the stage-wise distribution. A total of 56% of patients belong to early breast cancer, that is stage 1 and 2, and 44% to locally advanced breast cancer. Coming to BCS rates, among the, you see the entire cohort of BCS, the overall rate of the among 7 centers is 42%, and the mastectomy rate is 58%. Let's look at from stage-wise breakup of BCS. In the early breast cancers, the BCS rate was 53% in the current study, and the mastectomy rates were 46%. Whereas in LABC, 1/4 of patients are undergoing BCS, that is 26%. Coming to operable breast cancer, the median tumor size across all the centers, the data was available for 4,000 odd patients. The tumor size ranged between 2.3 to 3.2 centimeters. 41% were node positive clinically, whereas pathological node positivity was seen in 44% of patients. And as expected, majority of the patients were luminal patients, 69%, followed by HER in 20, TNBC in 16% of patients. Similarly, for LABC, the median tumor size reported ranged between 3.5 to 8 centimeters across all the centers. But the nodal burden in LABC is 85% of node positive. Let us look at the BCS rates upfront versus post NSET. Upfront, total of 60% of BCS patients underwent BCS upfront, whereas 40% had BCS following neoadjuvant chemotherapy in this cohort analysis. As expected, majority of the NSET patients were in the group of LABC. And 20% of EBC also had neoadjuvant followed by BCS. Most likely, these are the patients more than 2 centimeters with TNBC or HER positive patients. Localization techniques, we have some data available. Majority used wide localization for impalpable lesions, and one center also, our center, we also use intraoperative ultrasound. Margins, 5 out of 7 centers, they use routine frozen section, whereas 2 centers have reported experience with cavity shape. Coming to the margin status, overall margin positivity rate in the current study is less than 5%. We have with cavity shave, the margin positivity is 2.5. With frozen section, it is in the upfront group is 3.8%, and direct paraffin sections without frozen or cavity shave, it is around 4 to 4.5%. So overall margin positivity we can say is less than 5% among the entire cohort of BCS in the current study. More than 90% of patients received radiation, and the APBI rates is only 5%. Ipsilateral breast tumor recurrence is very encouraging. Only 1.5% patients had ipsilateral breast tumor recurrence. Regional recurrence was seen in only 0.5 of patients undergoing BCS. So just to conclude my talk, this is one of the largest multi-center Indian studies reporting the BCS rates. Overall BCS rates in the current cohort of 7,000 patients is 42%. Among EBC patients, the BCS rate was 53. Among LABC, it is 26. 1/4 of LABC, we are doing BCS. Upfront BCS is seen in 60%, and around 40% of patients are undergoing BCS after neoadjuvant chemotherapy. Overall margin positivity is encouraging. It is less than 5%. Ipsilateral breast tumor recurrence is only 1.5%, which is very encouraging. So we can conclude that the overall data indicates a reasonably good BCS rates and oncological outcomes. However, this is the data from one of the biggest centers, multi-specialty tertiary care centers. This will not reflect the BCS rates at a national level. So there is scope for further improvement. So with that, I would like to say that the reality is we have enough evidence for BCS. There should not be any debate between BCS and mastectomy, which is superior and inferior. We should stop offering mastectomy to patients who are suitable for BCS. We have adequate level 1 evidence. And I would like to conclude my talk. Thank you very much.